Hi everyone. Um, I just wanted to first of all really thank everyone for being here. And I'm going to begin by kind of going through an overview of what we've been doing so far in the last few months. It's not been an easy road, but it's been fun. I really want to commend the core team. We meet weekly. We did have a holiday on July 4th, but that was all we were allowed. But it's been such an exciting endeavor, and John couldn't have put better, when he illustrated and described the exciting times that we're living in, with all of the advances, in technologies to detect, AD biomarkers in blood. I was one of the naysayers, I should say, about 10 years ago, and it's just great to be here now and seeing the work and all of the efforts that also the companies here are working towards. So our work stream was dedicated to providing actionable recommendations to guide, the optimal adoption and implementation of blood biomarkers, wider spread into clinical practice. So we started with a literature review, and most people here will be very familiar with the Alzheimer's Association review that came out last year, as well as the CTAD EU task force, where they also started to think about how we can use all of the blood biomarkers that were showing such variability in terms of diagnostic accuracy for detecting brain amyloidosis. And of course, we wanted to kind of amalgamate that information into our own considerations. And we were able to start to identify some of the barriers, but also facilitators on how blood biomarkers could be adopted in clinical practice. Most of these reviews, so from our review of the literature, but also thinking around with our core team of experts and also disseminating within our larger work group meetings. So we met monthly with a full work stream. I think we're about 80 members. We started to identify some core themes, and most of them were really around, we kind of condensed them, and most of them were really around the need to really consider interpretation, but also optimal reporting of the results from these blood tests. We also started to think about, consider the ethical implications of, reporting blood biomarker results. And so we've been working with Workstream A, of course, and where they've described all of the appropriate use criteria, but also Workstream C to think about educational materials that will guide, the reporting process. And of course, other ethical considerations like around counseling. So I think one of the really great outputs, I should, if I could say so myself, from our work stream is really an overview of the patient journey. We spent a lot of time thinking through so many scenarios. We had, specialty care. So we had neurologists in our team. We had neuropsychologists. We had geriatricians. And everybody came together really thinking through, the patient journey around different contexts. So, initial setup where they're presenting with symptoms to primary care, but also upon referral to more specialist settings. And we'll be doing a deeper dive into it shortly. We were able to then submit an abstract for to AAIC. So we have a poster. We don't have it here, but I'm sure Emily will advertise our poster location at the end of this, where we really talk through some of the initial outputs from our workstream meetings. And then we're going to do a deep dive today on where we've really started thinking through those diagnostic algorithms and for how blood biomarkers could be used within the clinical care pathways and how to interpret the results for both primary care physicians, healthcare practitioners, and of course, most people will also be familiar with the Davos funded, real-world pilot studies with the brain health navigators. I love that term. And then, of course, we're planning our publication in September this year. So I'm going to hand over to Michelle.
And I also, before I jump in here, again, I do want to thank all the working group members. We've had fantastic discussions, haven't always agreed, but it's been a lot of fun. And you've put a lot of time into it. So thank you very much. So before we jump in to the work stream, I do want to again kind of repeat what John said and give you a couple disclaimers beforehand. So again, we did focus on U.S. healthcare system, but even within the U.S. healthcare system, the patient journey is going to differ depending on the insurance, on the symptom or symptom. Of course, this is just a kind of a general guideline. Um, the focus of our work stream was optimizing the patient journey for disease-modifying therapies related to Alzheimer's disease. So as you can see when I show you the next slide, there's kind of offshoots in terms of thinking about other diseases. We're not trying to those people, but it's taken us this long to get to just a guideline for disease-modifying therapies. So we'll have to consider the other scenarios down the road. And then with some of these, as I'll show you, we've gotten various feedback. We've talked to several primary care practitioners, healthcare providers as well. And sometimes you talk to them and they say, well, we can do these procedures in parallel. Some don't like to do it in parallel. So again, we've laid it out, but some of these steps are separated. So I realize that this is really hard to see. So I know your slides are going to come, the slides are going to be sent out. And actually, this is the reason I'm standing over here, because I couldn't see it from over there. So I'm going to highlight, go through. I know we don't have a ton of time, but really the numbers here. Again, we are focusing on symptomatic patients, patients that come in to a healthcare provider. And notice we specified healthcare provider as opposed to primary care physician, because some people will see nurse practitioners, some will see physician assistants, some may be general nurses for their first visit. So in the first step, they come in symptomatic. The healthcare provider will assess patient family history, clinical need, understand whether a further workup is needed and whether the patient is interested, which is of course important as well. If additional workup is needed, a healthcare provider will order or conduct cognitive screening, stress screening, and rule out blood work. So here I rule out blood work, thyroid testing, vitamin D testing, typical things that you look for other types of causes. If the healthcare provider has a continued concern for Alzheimer's, use the results with the patient, and the patient wants to go forward, there are there are two potential scenarios up here. So one, if the healthcare provider is comfortable, and we hope that over time there will be more that will be comfortable with this, can order additional tests, or it's possible that certainly they could refer on specialists. So the test that would be ordered would be a blood-based biomarker test, and then as well as a brain MRI and certainly others that they see fit as well. Again, can be done in parallel or can be done separately. And then if there is continued suspicion of Alzheimer's disease, patient and healthcare provider to go on further follow-up, they can be referred to a dementia specialist, where again, the dementia specialist can perform additional workup, maybe a different type of MRI, more extensive cognitive testing. After getting these symptoms back, if it's still possible, still thought that the person has Alzheimer's and may be eligible for a disease-modifying therapy, they could go on to another potential blood-based biomarker test. If, for example, there's one that's more accurate, if the more accurate ends up costing a little bit more, maybe you do the less accurate. Again, we're kind of thinking about all scenarios here. Or if the specialist decides that they want a different type of blood biomarker test, since we have amyloid and p-tau and others coming down the line. Again, if that comes back positive, right now we have that it will be followed up by a confirmatory CSF or PET. As I understand with the FDA guidelines, that may not be needed, but again, it also depends on the performance of the blood test that is used. After that, we have put in here, certainly we'll need APOE4 genotyping. We've put that at the end before determining DMT eligibility or before delivering it. However, you'll see there's a dotted line there because we've had many discussions as to exactly where in the pathway the APOE4 genotyping could occur, and that could certainly occur earlier as well. Do you want to oh, sorry, I've got it. So what we've also built into this patient journey, a couple different places, are how to consider or guidelines for considering the test and whether to refer on. So we've taken this in terms of if the physician has high suspicion of Alzheimer's disease versus a lower suspicion of Alzheimer's disease. So when it comes to the blood test, if they have a high suspicion and the blood test comes back positive, likely refer on to primary or to specialty care. If they have a high Alzheimer's suspicion, but the blood test ends up coming back negative, may also want to refer to secondary care. And again, although we're thinking about some of these blood-based biomarkers as triaging, there will be individuals that have FTD and other forms of dementia as well, in which case dementia specialists will be much more comfortable and able to do that diagnosis. If there is initial lower AD suspicion, test comes back positive, potentially refer to secondary care. Of course, it depends on the patients, but also to consider comorbidities if they have vascular factors, what their DMT eligibility might be, and what their next steps would be. And then certainly if there was low Alzheimer's suspicion and it came back with a negative test, really trying to understand what the causes of the symptoms are and not necessarily refer.
So I'm just going to start with just framing when we think about how blood biomarkers can be used for more confirmatory diagnosis. I guess the key critical difference between this and the triaging pathway, and we do think, I mean, for people who attended Susan's talk today, where she showed that beautiful data showing comparable, AUCs, for the p-tau 217, with CSF. I mean, that was awesome to see. So we expect this to happen soon as well. So for such scenarios, I guess the key difference between its utility as a triaging tool versus a confirmatory tool will be the exclusion of this step. And I'm sorry, where's the point? That's the point. The exclusion. Oh, okay. Ignore them. The exclusion of the step where there will be need for referral for LPs or for detection, for direct detection of brain amyloid pathologies, using lumbar punctures or PET scans. And this is so important because there will be patients who these tests are contraindicated for. But I think even from a personal angle as well, I think that when you think about the unavailability of these modalities in resource-limited settings, it shows how these blood biomarkers can actually, can extend from our thinking within the US pathway even towards more global settings. So I'll go to the next slide. So Michelle's provided a really nice overview. I can't see it very well, so I'm going to look at the screen here. She's provided a real nice overview of, the patient journey, through the triaging, and I've kind of explained what will happen, the caveat with confirmatory testing, where patients will not need to be referred for to either for CSF testing or PETs. But I just want to draw your attention to a few things here. So within the first step, as Michelle's gone through, so, symptomatic patients coming to see a healthcare practitioner or a brain health navigator once these become even more popular statewide. So the typical tests are performed, and if there is suspicion of AD, of course, the healthcare practitioner would then be able to order, the initial workup that will include like a cognitive screening, some behavioral screening as well, blood work to look at the reversible causes of dementia, and then of course we expect that the healthcare practitioner might or might not order an AD blood biomarker test at the same time as neuroimaging, and of course this will differ from practice to practice in terms of what's available. Where there's continued suspicion though of AD, we do have some scenarios that we've kind of put together as well, and items to consider, and this will include, so for instance, at the healthcare practitioner stage, where there is high suspicion of AD, and a positive blood biomarker result. Essentially, the healthcare practitioner can start to directly consider the patient for eligibility for disease modifying therapy, and start to have those conversations with the patient at that instant. If there is a high AD suspicion, but then a negative blood test, we would recommend that the high suspicion actually will supersede that negative test result, and the healthcare practitioner will need to start considering whether, either PET or LP testing is required to kind of determine what's happening in the brain. And then in terms of the interpretation, we're recommending that there should also be additional investigations of other tests to look at all of the different etiologies that might be contributing or be the underlying cause of the cognitive impairment that the patients presented with initially. So in the instance where we have lower, where the healthcare practitioner has low suspicion of AD, the clinical decision in such scenarios will be that the patient might be ineligible for disease-modifying therapies, and they need to start to consider other things, but also including CSF testing to assess for other etiologies. In terms of results interpretation, with a case of low AD suspicion by the healthcare practitioner and a negative blood biomarker test, we're recommending within the work group that it's likely that this might not, the underlying cause or the contributing factor might not be, of the cognitive impairment might not be attributable to Alzheimer's disease, but they'll be referred for additional workup. Where there's a positive blood biomarker, regardless of with the of suspicion by the healthcare practitioners, we are recommending consideration for disease-modifying therapies. But of course, as Michelle mentioned, there will be a critical need to also monitor, other contributors, including vascular contributions, but also comorbidities as well.